I'm Dr. Thompson Akwo, Ntuba, the editor of Health and Development magazine, and we are at the NS Montreal Convention Center, downtown New Orleans, as part of the American Academy of Physical Medicine and Rehabilitation annual meeting 2016. And with me is
Dr. Jonathan Ho from University or with Wayne State University School of Medicine in Dearborn, Michigan.
Thank you, Dr. Jonathan. You have been attending some of the sessions here. Are you here as part of the presenting faculty, or you are just an attendee?
An attendee, but I'm presenting a poster.
Oh, wonderful. What's your poster about?
Chemo-induced myositis, so muscle pain from chemotherapy.
Chemotherapy, which should indicate that you would be dealing with patients who are suffering from some form of cancer.
So some patients, when they go through cancer chemotherapy treatment, they may experience some muscle pain and joint pain, and I'm just documenting a rare side effect of a class of the chemotherapy agents.
That is in cancer involving which tissue, organ, system?
Well, this medication is used in all kinds of cancers, but in this particular case, is breast cancer.
Breast cancer, and October is the breast cancer month, so that's wonderful catching you with your research. Let me find from you what you do during this month for women who are survivors or who may be afraid that they may come up with breast cancer. What would you say are some preventive measures you put in place?
I think that it's just self-education about the guidelines for self-exam and meeting with your primary care provider, and also OBGYN to talk about breast health and women's health. I think that's a very interesting and important topic that we need to focus on, and having a good discussion with your physician is a good place to start.
Your paper that your poster presentation, what's the title?
It's called Docetaxel-Induced Myositis, a case report.
And that medication is given for as chemotherapy in breast cancer. At what stage is it given as with the intention to cure, or as a palliative to prolong life, or what?
I think the goal for breast cancer regimen is for cure. It's part of the treatment prior to the breast conserving surgery. There
are some stages where the grading, which is a pathological thing, and staging, which is a combination of pathology or histopathology and clinical findings, will have metastasis or dissemination. Even with metastasis that have disseminated to other tissues and organs, are you expecting to have a cure with the medicine?
To be honest, in that case, I cannot be sure. So part of what I do with the cancer, the oncologists and cancer patients, is that I assess for functional impairments, and then tailor a program of therapy to help improve the quality of life and function. With regards to the chemotherapy and the stages of medication, that will I leave up to the oncologist.
The oncologist. So you work in a team with oncologists.
Yes.
To take care of pains,
Yes.
that are sequelae of cancer.
Yes.
I want us to be clear to the public. There are lots of people who say that when people are in end stage of cancer treatment, they are in hospice care, there is need for control substances to be used, opioids and related medications, which lead to addictions. Will you be bothered about people who are in end stage cancer diseases vis-a-vis addiction, since you may be assuming that they may die anytime? Do you think that there should be nothing like restrictions on the different addictive pain relieving medicines we use?
I think before you start or increase the dosage of narcotic medications, you need to have a really frank discussion with the patient and the families as to determine what goals, what is the expectation from this medication, this class of medication is. Can we completely eliminate all pain? It's likely not with only one or two drugs. So in my practice, I speak with the patient and I come up with a multidisciplinary approach. So I use topical medications, oral medication, therapy, injections, to try to control pain so that way I don't need to use as high of narcotic dosages. Some cancer patients do need high dosages of pain medication. And I tell them that our goal is to reduce or to make you feel comfortable, not to take away all the pain. And I tell them that the higher that we go, there is a chance for addiction, intolerance, and we need to monitor any behavior that could lead to a risky drug diversion. But I think in my patient population, I have not seen that yet, but I'm not saying that it's not there.
Wonderful. There are many, finally, in just 1 or 2 minutes, there are many physicians or colleagues out there who think that some of the things you do in physical medicine and rehabilitation are done by orthopedics, neurosurgeons, people who deal with spine and central nervous system problems, musculoskeletal. Many of them are dealt by the orthopedics. Rehabilitation is also done by different people. Why should we be talking about a specialty of its own where physiatrists like you are involved in?
So each field focuses on a specific area of the body, and for physical medicine we overlap with many different fields, but our aim is the same. It's always about patient's function. The patient can have an amputation because of peripheral vascular disease. Yes, the vascular surgeons take care of the leg, but we prescribe the orthotics, prosthetics, and we tailor the therapy programs. We discuss goals. We discuss returning back to work. Same thing with strokes. Neurologists administer a TPA and initially diagnose a stroke. However, functionally, we become involved after they sustain a stroke. So even though, yes, other specialties do what we do, but our focus is different. And so I think that's why we work with the team, we work with the specialists to care for the patient to improve function.